Hi, this is Dr. Seth Ganz with Agile Veterinary Surgery, and I'm here to talk to you about cranial cruciate ligament disease. Cranial cruciate ligament disease is a very common problem in dogs, occasionally cats. It can affect almost any size breed of dog. There's a couple of exceptions. Greyhounds and some related breeds tend to be less prone or even protected or immune from this problem. But in most of our other dog pets and patients, they can succumb to this issue. It doesn't happen to everybody, but we see it a lot in orthopedics in dogs. We call it cranial cruciate ligament disease because it differentiates it from an injury, meaning, when you think about a ligament tearing in a knee, which is what this is, you might presume that there was some trauma that brought it on, either that there was some excessive force that got applied to the knee during activity that caused a ligament to tear, or that there's been some chronic stress that somehow the activity, behavior, daily life is kind of responsible for this, and that is almost never the case. So the reason we call it a disease is because even though we don't understand what kind of sets it off, despite a decent amount of research, we just know that it's sort of more of an internal process than an external process, meaning in a dog that's going to tear their cranial cruciate ligament, it's probably going to happen, at least currently with our lack of understanding of what causes it and our lack of effective preventative treatments. It's not going to be created by something they did or didn't do. It's kind of inevitable in that patient. It's kind of neither here nor there for a patient that gets the problem in that knee, because the results of the disease, as we'll talk about in a second, is still a mechanical issue, and we fix it in a mechanical fashion with surgery. But it's helpful to know, just to know that nobody did anything that they weren't supposed to do. And it's probably most important to realize that because it's a spontaneous thing that has a trigger that we don't completely understand that affects this one ligament inside of the knee, that it would stand to reason, and it's also kind of borne out in just seeing patients and looking at statistics, that if you get this problem in one knee, there's a significant chance that you could end up having it in the other. And depending on which study you read and what your experience is, people will quote different numbers. I think it would be fair to say that depending on the situation, it's 30 to 50% likely that if you have this diagnosis on one knee, that you can get it on the other. And a fair number of our patients are diagnosed bilaterally and have it in both knees by the time it's recognized as well. Okay, so the disease happens, the ligament weakens. You can picture it like fibers of a rope. It's not a solid piece. It's made up of different components, fibers, and you can have partial tears. Some of it separates and you start to get less of a function of that ligament, and all the way to complete tearing where there's just no connection there anymore. So the consequence of that is that that ligament's there for a reason, and the reason that it's there is because without it, the bones of the knee, the femur bone up in the thigh and the shin bone or tibia, don't move against each other in as normal of a way. And I'll bring this picture in and try to help show. So this is a dog's knee, and in this picture the dog is going to be facing this way, so their head is to this direction and they're standing up in this picture, and here is the femur, the thigh bone coming down here. This is the tibia or the shin bone, and the ligament, a little hard to show in this picture, but the ligament is right in there. So it starts in the front of the shin bone and runs towards the back of the thigh bone. And there's lots of other ligaments in the knee that have different jobs, but the job of this particular ligament, above all, is to prevent the shin bone from sliding forward towards their nose when the dog takes a step. Sorry, that way. So dog is standing, facing in that direction, and they're standing on the leg, and the ligament's in there, and now you have this femur bone, thigh bone, that's very round at the bottom, and the shin bone or tibia comes up and over and then slants down like this on the surface where the femur bone rests. So it's not flat. In people, the top of that bone is flatter. So when you think about that, when the dog takes a step, there's natural compression that happens through the joint. There's a muscle that pulls up, your quadriceps muscle pulls up on your shin bone without you even thinking about it, and it squeezes those two bones together. And if you think about these two shapes being squeezed together, with this bone being very round and this bone being slanted, that as they come together, the shin bone is pulled up, but then it starts to slide forward a little bit. It slides along that angled surface against that round bone. And when the ligament's healthy, it's right in there and it stops it from happening. It just is tight and short, and it doesn't stretch. When the ligament is torn, then the shin bone starts to buckle forward, and we call that tibial thrust. And the result of that is limping, and the reason for the limping is pain. And the connection between all those things is that if your joint shifts, it stretches on the capsule, the sheath that kind of encloses the joint surface. There are nerve fibers in that capsule. I always kind of hearken to the analogy of a bad sprain in your ankle. If you've rolled your ankle over, which most of us have done, in most of those cases, we don't break the bone, we just stretch the joint out, and our body tells us that. As soon as we kind of realize that we've stepped funny, then there's a pain signal, and sometimes that pain lasts for a little while even after that fact. Well, I think about this as the dog takes a normal step, but internally it creates that same feeling of the joint getting stretched out. Now within this whole area, there's also this gray pad represented here. That's the meniscus. And as a result of that instability, in addition just to the pain of the instability, you can have tearing of that cartilage too. It can get damaged between the moving parts of bone that are shifting abnormally. Those are the sources of pain. Those are the reasons why dogs with this problem limp, and that informs how we treat the problem. Until or unless we get rid of the instability, we're not gonna make the leg more comfortable. Our dog is not going to want to put more weight on it, because they know the more weight they put on it, the more painful it's going to be. So there's different treatments that are available for this. I'm going to focus on what I do, which is called a tibial plateau leveling osteotomy. There's a reason why I do that surgery. I find that it's the most consistent, highest level of result. It's durable, so it kind of hits all the check boxes that we would want. We want a one and done surgery. We want it to result in as close to normal function as possible, hoping that it looks like when we're all healed up and recovered that nothing's ever happened, best case scenario. And we want them to be able to do what they want, not just look good doing it, but be able to do that stuff without a lot of restriction, without a lot of pain medication long-term, if any. So that's why I do this surgery this way. And there's also in my hands a low complication rate. There's not a high incidence of things not going well and needing to be redone. So we'll proceed talking about just this surgery. The nature of TPLO, as the name implies, it stands for Tibial Plateau Leveling Osteotomy. So the tibial plateau is this slanted surface here, and we're going to level it. We're going to make it more flat, because as soon as we do that, and we'll show in the next picture, we're going to restore some stability to the joint. Tibial plateau leveling osteotomy, we're going to talk about a cut in the bone to do that. So here's kind of a before and after. So this is back to the same picture we were just looking at, and here's right in the middle of the surgery. We've made a cut in the bone. This cut curves through the top of the shin bone. The surface of the shin bone is not removed or damaged, it's maintained, but as we cut along that curve, we then turn that piece of bone this way, okay? And so now the surface is level, We haven't removed anything or added anything. We've cut underneath the surface of the joint, so everything inside of the joint is still as it was. And now we have a new kind of funky shape to the bone. Now we've cut the bone in order to manipulate it into this position, so it's not going to stay there on its own. So we place a plate right across there. There are screws 1, 2, 3, 1, 2, 3, depends on the size of the patient. This would be a standard size that go all the way through the bone to hold it in this new position. The idea is that when we cut a piece of bone to the body, that's just like a broken bone, and it's going to start healing right away, just like a broken bone should. And when we break a bone or cut a bone surgically and we repair it properly, usually within about 2 months' time, it's healed solid again. And a little bit after that, it's actually 100% full strength back to where it was before. That's different than most tissues in the body that when they heal don't get back to full strength. So that's where the durability comes in. But this plate will hold the bone into its new position. As we heal and recover and let this heal without too much high impact testing, then the bone will assume that new shape. The bone will be solid in this shape, and the plate will no longer be needed, but in the vast majority of cases just stays there as an inert object. So the idea is now that the knee is stable without placing anything across the joint that could stretch or break over time, that could harbor bacteria and need to be removed with infection, and we tend to get really good results. So that is a tibial plateau leveling osteotomy. What goes into the surgery beyond the doing of it? Well, the recovery is a big deal. We're talking again about 2 months at least of bone healing, and we're talking about it in a patient that is not reading our instructions, either feeling good, feeling bad, hopefully within a week or two after the surgery, overall feeling pretty good, but we have to impose our will on our pets to make sure that they recover smoothly, that they progress the way they're supposed to, and that most importantly we don't invite any significant complications because of overactivity while the bone is still kind of in that fragile state. So I always give detailed instructions with my patients after surgery, but as far as general expectations, it's 2 to 3 months of restricted activity with progressively longer walks on a leash, always under control, always nice and slow. But you can, as the weeks go on, walk longer and longer. So we do want movement of the joint, we want maintenance of muscle mass. It's not a total shutdown, but running, jumping, playing with other pets is hazardous to the success of the surgery. And to be frank, if we push the limits early on after, everything we did in there can break and be harder to repair a second time. So we want to do it right the first time for sure. The good news again is that the vast majority of patients benefit significantly from the surgery. I mentioned the meniscus. We, when we're in surgery, look at the meniscus to see if there's evidence of damage. In some patients, the meniscus looks fine, and that's good to have it there and be healthy. In that case, we leave it intact, and in most patients, it serves them well for the rest of their life. If they have a healthy meniscus and we leave it, there's a rare occurrence that they could just tear the meniscus cartilage down the road, and that could require a second minor procedure to remove that torn cartilage. But if it's torn the first time when we get in there, we remove the torn part. It's not the whole thing, it's usually less than 25% of the whole meniscus, but by the time we note the damage in there, there's no real repair that's an option in these guys. It just has to be cleaned out. So that can be dealt with either way. But the only other common, and when I say common, like meniscal tears 5% of the time or less, the only other complication that reaches those numbers would be infection. Infection can happen despite everyone's best efforts. We can never get infection down to 0%. So every once in a while we'll have infection. And what does that mean? Well, in most cases that we have infection, it means that we have to give more antibiotics than what would be typical, which is usually 2 weeks right after surgery. Sometimes it means that it keeps coming back. And what does that look like? Well, infection can look obvious on the surface of the skin. A lot of times it's not. It's more under the skin because there's a piece of metal in there and that's not part of the dog's body. So sometimes that can trap or harbor bacteria, and the immune system can't quite get to that metal to clear out the bacteria on its surface. So in those cases, we'll see pain, more limping than we should at a certain stage, because infection is almost always painful. So sometimes it's just we're tipped off by more tenderness and more limping. Also, if we recognize that and we put a patient back on antibiotics and everything's better, that gives us a pretty good indication that there was an infection there. But sometimes we go through a round or two of that and it keeps coming back, and in those cases we have to remove the hardware. Less than 5% of the time we have to do that. Good news is it's a relatively minor surgery if we have to do that. It in no way negates the original surgery, because now the bone has healed into its new shape, and that new shape has conferred stability to the joint, so it doesn't make them any worse for the wear. It just takes care of the complication in most patients. But those are minority. Most patients have one procedure, do great. And what is that? When I say do great, what does that mean? So, not limping at all would be a typical expectation, that they just look normal. There are some shades of gray. Can have a little bit of stiffness, a little bit of limping when getting up after a long rest or after a lot of activity, but usually that's self-limiting, self-resolving, doesn't require intervention. Arthritis is part of the disease even before surgery, and certainly doesn't go away with the surgery. We don't even stop arthritis with surgery, but fortunately we don't tend to see the manifestations of arthritis where we have a stiff patient that gets more and more uncomfortable as they get older, that requires long-term medications. Most of these guys and girls have about 2 weeks of medication, a few days of anti-inflammatory, a couple weeks of pain medication, antibiotics, and most of them, unless they have other concurrent conditions, do not require any medication long-term, maybe just a joint supplement. And so minimal to no limping, no restriction. I strongly encourage patients that get through the rehab process to go back virtually 100%. Why is that? It's not like we want to push the limits and see a problem, but if you're thinking about, well, what about the other knee? That again is not caused by their activity level. So if it's going to happen, it's going to happen. It's much better for it to happen to a patient that's in shape than out of shape. Being in shape is good in and of itself, obviously. So we want to stay thin, we want to stay fit, and that's just good for quality of life. It's good for longevity. So the surgery, once it's done and solid, it can take it. As a matter of fact, building up muscle after the bone's healed is good for having a better result. We tend to see, continued improvement over the 3, 4, 5 month period. So ultimately, the best case scenario is, and the most common scenario, fortunately, is it kind of becomes a problem that you forget was there, and that's all we can ask for. So I hope this answers a lot of questions you might have about this condition and about the potential treatment, and I hope I get to help with it sometime, but definitely feel free to reach out to me if you have any more questions. Thanks very much.